Thank you for joining me for this episode. Today we're joined by Dr. Kaleb Abbott, and we're going to be speaking about rosacea and how we can go about treating it, particularly with IPL on the OI Show. Before we get started on this episode, I wanted to mention that Optometric Insight has been sort of supported both through our closed program and our student workshop of the ocular surface through MD Elite. MD Elite has a device that does IPL, a radio frequency. They also have a low-level light device that both Dr. Brujic and I have been using successfully. We've really enjoyed the simplicity with which this way brings about a more comfortable IPL experience for our patients, and I'd recommend that you check them out. Thank you for joining us, and now back to the show. Thank you for joining us. I'm excited to have Dr. Kaleb Abbott joining us today. Thanks for finally getting on the podcast. We're finally meeting and finally getting to hang out with a dry eye guru, which I'm excited about. So thanks for being here, buddy.
Of course, happy to be here. Thanks, Dave.
Yeah. And so Kaleb has a unique practice setting in the university where he's almost exclusively just doing dry eye. So how did this come out to be that you're doing what you're doing, and how is it that you're just doing dry eye?
Yeah, so my predecessor, Scott Halsworth, was working in our dry eye clinic and really built up our dry eye clinic from scratch. And I kind of feel like sometimes I'm standing on the shoulders of a giant in that sense. But when he departed and went to industry at Dompe, where he's doing great things, I kind of had to step in and start seeing all of his patients. And I was quickly thrown into the fire where all of a sudden I was seeing a lot of very complex ocular surface disease, a lot of corneal nerve pathologies and neuropathic pain syndromes and different things like that. So was quickly thrown into the fire and had to learn as fast as I could. But now it's over the course of the last few years, I was able to transition from doing kind of half dry eye and then half comprehensive to exclusively dry eye and ocular surface disease.
Wow. So on a daily basis, like, and you just told me that there was months, but like you're just seeing dry eye patients all day long, and that's probably
Yes.
probably not the patient who comes in and says, "I think my eyes feel a little dry." These are probably more advanced cases most of the time. Would you agree?
Yeah, so I guess my day to day is I am about 70% clinic and about 30% research. So when I'm not in clinic doing dry eye, I'm doing a lot of clinical trial research and systematic reviews and just a lot of dry eye type research. But then, yes, you're right. When we see patients at our dry eye clinic, we're typically kind of the patient's fifth or sixth stop. So we're kind of a
Mm.
tertiary referral site within our department, we get referrals. Within the entire hospital system, we get referrals, and we get referrals from optometrists and ophthalmologists throughout the entire state and even surrounding states.
So so I have a dry eye referral center as well, and I'm curious to hear how you might answer this. What would you say is the number one treatment that people haven't tried by the time they come to you? Because all these patients have come in and they've tried all of these different things. One of the things I oftentimes is that they try a prescription medication for a couple of weeks and they say it didn't work,
Yes.
right? It's like, okay, well, it was only a couple of weeks. That was probably part of it. But what would you kind of say is the thing that you go to often, not in every case, but hasn't been tried by the time they come in to see you?
That's a great question. I feel like it's kind of evolving as we get more and more dry prescriptions. I think a lot of the patients coming in just haven't tried the newer dry prescriptions. So that's kind of a low
Hmm.
hanging fruit answer. But one thing that we kind of prescribe quite a bit that patients typically haven't tried is autologous ceramide drops or PRP eye drops, and then trying to do kind of advanced procedures. A lot have tried IPL, but sometimes we end up doing things like meibomian gland probing with patients or amniotic membranes. I'm always surprised at how few of optometrists and ophthalmologists do kind of well-known procedures like amniotic membranes.
Hmm. Hmm. So let's dig a little bit into some of these advanced procedures, and just because more people are getting into this. So having been something you've done for a long time, you probably see a lot of overlap with rosacea. And when I asked if you could come and talk to me, that was one of the topics I wanted to discuss with you. So where do we really see this? It feels to me that all of a sudden when I got IPL, all of a sudden all my patients have rosacea. And it was almost as if just like when Tarsus developed the drug, it was like, oh my gosh, there's like a
Everyone
lot
knows
of
Demodex.
Demodexes, right?
Yes.
So it was kind of like our
Yes.
eyes got open. But tell me about the correlation you're seeing.
Yeah, well, to quote one of our uveitis specialists, you only find what you're looking for. So sometimes you get a new device and then you start looking for things. But ocular rosacea is one of those things. When you start looking for it, you will see it everywhere because it
Mm,
is so prevalent. I think it's one of the most commonly missed ocular surface conditions that exists out there. So we commonly get these patients that are sent into our dry eye clinic. And the referral note will say something along the lines of, this is a disaster case. This patient has blepharitis, they've got Demodex, they've got recurring bacterial conjunctivitis, they've got chalazion, hordeola, styes, they've got dry eye, they have MGD. It's just too much. I'm sending it to the dry eye clinic. And we take a
hmm
look and we say, yes, they have all the things you just listed, but there's one overarching mechanism that is causing all of that, and that is ocular rosacea. So they have ocular rosacea, and then what you're seeing are all the downstream manifestations of the ocular rosacea. And I think a lot of times as practitioners, we get so caught up in, well, I've got to treat, the allergic conjunctivitis and the dry eye and the MGD. It's just so much. But if you can think about kind of take the broad view, the aerial view, and realize really you're treating ocular rosacea and then you're treating the downstream effects, it makes it a whole lot easier for you to wrap your brain around it, for you to come up with a treatment plan. But more than that, it also makes it a lot easier to explain to patients who just keep wondering, why do I keep getting all of these styes? Why do I keep getting these bacterial conjunctivitis? Why do my eyes itch all the time? Why do I have light sensitivity? And when you can explain to them the pathophysiology involved, it's really nice for you as the practitioner and for the patient.
What do you tell them? What you said you explained to them the pathophysiology and jaw. How do you describe ocular rosacea to these patients?
Yeah, ocular rosacea. I mean, if you ask 10 people what ocular rosacea is, I think you'll get 10 different answers because it is a
And
very
some of them
complex
might give you a
condition.
couple answers, right? So you might
Oh,
get
yes.
13.
Yes. I mean, there's so many things that are going on with ocular rosacea. So, I mean, firstly, it is a condition where you have an abnormal amount of dilated superficial blood vessels on the eyelids. Like that is really the hallmark definition of what it is. But there's so many other things that are happening too. So you've got it's really a neural disease where there's vasodilation is greater and more persistent. There's an autoimmune component where the body is overreacting to certain triggers. And so that's what's leading to flares in these patients. They're because of the warmth associated with all those blood vessels on the eyelids, we start to see that there's an increased Demodex load and an increased and altered bacterial load on the eyelids. We see that it's associated with systemic conditions like the gut microbiome. We
Yes.
see that there's many different things happening, a lot of inflammation. So it's hard to explain to patients, but I always say kind of at the root of it, you can blame your parents because you were born with kind of this tendency to have these superficial dilated blood vessels that cause a lot of inflammation, and your body overreacts to certain triggers that ends up causing flares for your eyes.
Do I have to have rosacea to have ocular rosacea?
Oh, that's a good question. So you do not. And there's a lot of disagreement between optometry slash ophthalmology and dermatology, kind of on what it is. Because if you ask dermatology, they'll say about 20% of rosacea patients initially present with ocular rosacea. They say that facial rosacea almost always precedes ocular rosacea. But if you ask people in eye care, we'll say things like, we'll find ocular rosacea in up to 75% of rosacea patients, but that 90% of patients with ocular rosacea have minimal skin findings. So
Mm.
there's many times that we see ocular rosacea in the absence of facial rosacea. And that's one thing that I hope listeners kind of take away from this is that it's okay to give a patient a diagnosis of ocular rosacea, even in the absence of a diagnosis of facial rosacea. We don't have to be scared to give that diagnosis.
So sometimes when I'm looking for it, I look for the facial rosacea as some of my diagnostic cues. What do I see in an ocular rosacea patient who doesn't have systemic rosacea?
Yes. So, I mean, there are different types of facial rosacea. If you understand what's going on with the facial rosacea, it makes understanding ocular rosacea a lot easier. It makes it a lot easier to diagnose the ocular rosacea if you see the facial rosacea because it kind of clues you in what to look for. But if you're assuming that there is no facial rosacea, really the hallmark that we see in these patients is that they're going to have lid margin telangiectasia. So they're going to have these superficial blood vessels on the eyelid margin that are kind of going from the eyelashes towards that lid margin where the meibomian glands are. There's going to be a lot more of them than you see with the average patient. And when you look at it, they're going to look more superficial than the average patient. The average patient, they're a lot deeper. They're kind of hard to see. There's not a lot of them. With these patients, there's a lot more of them. They're more superficial and they're easier to see, and they may go all the way from the eyelashes to that lid margin. Then you might see associated things like lid erythema, maybe a little bit of lid edema. You could see blepharitis. You could see MGD. You could see collarettes associated with Demodex blepharitis. You can see just redness of the lid and even redness of the eyes as well. So those are kind of signs that you'll see along with those lid margin telangiectasias.
So is it safe to say that if I see eyelid telangiectasia, that that patient has ocular rosacea?
Um, it
You
so
somewhat
not
kind of
not always.
differentiated that.
So
So I
not
just, yeah,
not
clarify
always.
that.
So because there's one case that I can think of specifically where a patient looks like they have ocular rosacea and they don't. That's a patient that has glaucoma that's been using the glaucoma drops like prostaglandins, where it
Sure.
kind of shrinks away kind of the fatty tissue around the eyelids. Now those deeper blood vessels are dilated and exposed. So it looks like they have ocular rosacea, but they've been using these prostaglandins or other drops that kind of mimics ocular rosacea. So in those patients, you really have to ask them the questions like, do you have flares of your symptoms, of your dry eye, of your MGD, times that it's worse? Is it triggered by sunlight? Is it triggered by red wine, spicy foods, lack of sleep, increased stress, things like that? So not always is it ocular rosacea, but I'd say the vast majority of the time it would be ocular rosacea if you see those dilated telangiectatic blood vessels.
So I see them now, and whether or not they have facial rosacea as well, uh, talk me through treatment and what you're going to do for those patients. Um, obviously you're treating dry eye as well, and they have it dry eye because of, but what are
Mm-hmm.
you doing specifically to maintain and manage the ocular rosacea? What are the various different things that you're treating? Historically, we just thought we'd give everybody Doxy, right? But we also have that aspect of the gut microbiome, and that brings into a play conversations
Yes.
that I don't even know very many of us are smart enough to have that conversation yet because it's so deep and there's so much. And we've had Mila Yosifova, who's an expert in the gut as well as the eye, and you're an expert in that world a little bit. But I've seen more and more of us shying away from going the oral route. Um, and then also, what do we do for people who have MGD? That classic thought
Yes.
is warm compresses. So where,
Yes.
how are we talking through? Walk us through your treatments for these patients.
So you really have to, once you know that there's ocular rosacea, you have to try to figure out what are the manifestations of it that are causing the most problems for patients. Pretty much always with ocular rosacea, there is a degree of inflammation. So if there's a degree of inflammation, a topical immunomodulator is helpful, cyclosporin or lifitegrast. And then I oftentimes give patients a steroid, a light steroid to use as needed for flares, twice a day for 3 to 5 days during a time of a flare. But you have to figure out
Hmm.
if there's inflammation, you have to treat that. So you could be using things like steroids. You can use oral antibiotics. I've been kind of shying away from the oral doxycycline. There's a study that came out last year that shows us topical azithromycin works just as well as oral doxycycline, but with less side effects. So I do a lot of topical
Hmm.
azithromycin compounded at Imprimis RX. It's a pharmacy, I think, out in New Jersey, and it costs
Yeah.
my patients like $45 for 3.5 milliliters, and it works great. So you can obviously, we'll talk about IPL in a moment, but if they have MGD, blepharitis, hordeola, you have to target that route too. So for that route, we see that again, topical azithromycin can be helpful. So can topical immunomodulators, but you might be looking at procedures like blepharoexfoliation, thermal pulsation, IPL, meibomian gland probing if there's a lot of keratinization. And there's some evidence that topical lodolan or so XDIMV can actually be helpful to improve meibomian gland dysfunction in this setting. of Demodex blepharitis and ocular rosacea. And then if they have dry eye, you kind of have to also be thinking about the dry eye. So if they've got kind of corneal staining or keratitis look to it, it's possible that the ocular rosacea can lead to something like aqueous deficiency, where all of that inflammation that's happening is end up going to the lacrimal glands. They don't function as well. So sometimes those patients become aqueous deficient. They respond better to things like autologous ceramide drops. Um, some in rare cases you might have to find yourself doing scleral lenses. But kind of two things that I shy away from, and you kind of hinted at one, is warm compresses. Typically, warm compresses make this worse. You're putting heat on an already very inflamed eye. You're causing further vasodilation, and that can cause problems in patients. When we look at what our dermatologist colleagues do for facial rosacea, they're never doing anything like that. They're typically shying away from causing more vasodilation. In fact, they use vasoconstrictors. So they do azelaic acid, they do brimonidine gel, they do things like that to constrict the blood vessels on the face, not just for cosmesis, but to decrease inflammation. Because remember, those blood vessels are unhealthy blood vessels that are driving inflammation. The second thing I usually shy from is punctal occlusion. In my experience, it oftentimes just makes these cases worse, unfortunately. But the best thing that you can really do, and the gold standard, is IPL. IPL really targets
Mm.
every single facet of ocular rosacea. This is the bread and butter of IPL. You're targeting those, you're really sealing off those superficial dilated telangiectatic blood vessels that drives inflammation. You're improving MGD. You're helping with the kill the Demodex. You're helping with the bacterial overload. You can help with the blink mechanics and the cosmetic appearance. That can really, really help patients out.
So, when we talk IPL, saying that we do IPL is kind of like saying somebody drives a car, right? But the reality is you can be driving a race car or you can be driving a off-road truck, and those are both driving, right? But doing IPL can vary across the spectrum, and I think it's important for us as educators to kind of dig into what do you mean by doing IPL? Particularly if they have facial rosacea, is your recommendation to do a different type of treatment compared to just around the eye? So walk us through your protocol of what you might do for patients, and are you using different filters? Are you comfortable talking about
Mm,
what you're doing for those patients? I'm sorry to be so
that's
granular, but I think
no, that's a
that a
good
lot of
idea.
people are like, "Oh, hey, let's just do IPL," and it's like, well, what do you mean?
Yeah, so it largely depends on the device you have. The device that we have is the Rohr Aesthetic Spectrum, which I only know of two other ODs that have this one. So ours is a little bit different, but we've got multiple different types of filters. We will use a filter that is more classically a dry eye filter for the first pass. That's closer to kind of that 580 nanometers. We'll do that
Hmm.
usually for the first pass, but then the second one, we really like to use a vascular type filter that is
Yeah,
lower wavelength. I think it's closer to 510. And we like to
yeah.
use that vascular filter because it's really targeting those superficial dilated blood vessels, the telangiectasias. So typically I will do two different filters. I'll start with the higher wavelength, then move to a lower wavelength. There's no data on this guiding what is really the best. So, I mean, you can really justify many different things, but I mean, it's probably best that you're at least using some sort of vascular filter in these patients.
Yeah, and I think it's key that you're bringing up to use both of those filters, particularly in your rosacea patients, and you're doing multiple passes. I know some people might do two passes with both of those, right? Because you're
Hmm.
really targeting different levels, and putting a lot of energy in there, and skin types and so forth all play into that, and that's something people can look a little bit into. What about um, there's all sorts of things in the literature. We're just doing a literature review again with my resident and looking at IPL, and we're all over the place as far as the protocols that are out there and so forth. How many sessions you do. There's studies that talk about 2 to 3 sessions, up to 5 sessions. Are you spreading them out over weeks, or are you spreading them out once a month? And then, so there's all sorts of things. What do you do? What are your recommendations?
Yeah, a lot of it still unfortunately depends on the device that you have. But when it comes to IPL for rosacea specifically, we know we know the cases that IPL works the best for. So there's really two things that determine if a patient's going to be successful with IPL. The number one thing is how symptomatic they are. The more symptomatic, the more likely it is IPL is going to help. The second thing that we know tells us whether or not IPL is going to help the most is literally the number of those superficial dilated telangiectatic blood vessels. So the more blood vessels they have, the more symptomatic they are, the more they need IPL, the more sessions of IPL they will also need. So when it comes to typical dry eye, I'm oftentimes telling my patients we'll do 3 initial sessions and then we'll see how you're doing and decide how we're going to space the maintenance sessions. But when it comes to rosacea, I try to lean on the side of doing 4 initial sessions for these patients. And then I tell them, you will need more frequent maintenance sessions. This is what the literature tells us. The more blood vessels you have on those eyelids, the more often you need IPL. So I end up finding myself doing sessions with those patients more frequently. And I think that that's needed because the last thing you want to do is let too much time lapse and then
Yeah.
find that you're kind of trying to play catch up and having to do a lot more sessions to
What
catch up.
is what does success look like after those first 4 sessions? When I first did IPL on my patients, I expected to go back and look at their eyelids and have them be completely white with no blood vessels. And then for quite a while, I thought maybe I failed and IPL didn't work because there were still blood vessels there. So what should we be expecting as success for these patients?
That's a great question. So I don't make promises on redness with my IPL patients. I know some people do. I don't like to make promises on that. I'll say like we can try to treat the redness. We can try to get rid of some of the lid erythema, things like that, the number of visible blood vessels.
Yeah.
But that's difficult because this is something you were born with. This is innate to your own anatomy. It's very hard to change anatomy. So, I mean, success to me, I want to see that there is reduced inflammation coming from those glands. I would ideally like to see, less blepharitis. I want to see improved meibum quality, improved number of glands that are secreting. I want to see, ideally, if there's lid erythema, that's better. I don't want to be seeing styes and chalazion and hordeola forming after IPL. I want to reduce, the frequency that's happening. Hopefully, just eliminate it and overall just improve their symptoms. I think a lot of what we're doing with IPL, that we're trying to just improve the symptoms that are most bothersome for the patient. That's why we very carefully track, pre and post IPL doing surveys. We very carefully track literally the number of glands that are secreting, tear breakup time, the quality of those secretions. Then we can go and we can tell the patients, here's what you were pre IPL, here's where you are now. And I would say when it comes to rosacea patients, these are kind of the biggest slam dunks. Like these are the most predictable outcomes in terms of you being able to improve all those numbers.
Yeah. So, does manual expression with IPL fit into your protocol? Are you manually expressing?
Yes, we manually express the lower lid. We don't manually express the upper lid. Some people do that, but we just do the lower.
Do you do all of the IPL treatments yourself, or do you have somebody in the office that does it?
Yeah, at the University of Colorado, we have to do it all ourselves. We can't have anyone else do it.
So you're right there anyway to be able to just take that patient. And then is this something that you're scheduling a half hour per treatment for, or are you doing quicker than that? Like I
Yeah.
presume you probably have a lot of patients per day that are getting IPL.
So a lot of this depends on the tip that you have on your device. The larger the tip, the less spots you need, the faster you can do it. Our tip is very small. It takes forever. It's zap, zap, zap. For I mean, some of these patients will be doing it, 70 pulses,
Yeah.
70 spots with these patients, 70, 80. I mean, it can take a while. And then at our university, we have to jot down, we have to record all of this stuff all over the place. So we have to sign consent forms in a different room than we do the IPL. There's tons and tons of measures and hoops we have to jump through. So we set aside 30 minutes.
Mm-hmm. Mm-hmm.
We set aside a whole
Okay.
afternoon just to do IPL and meibomian gland probing.
Yeah. Okay. Well, that seems like a good efficiency. Um, and then I guess the other kind of question around your IPL procedures are how often are you recommending people come back and get retreatment? Do you know that when you're setting up their we're going to do four on you? Do you say, hey, we need you every 3 months, or we need you every 6 months, or once a year is good enough? How do you decide, and when do you
Yeah.
decide that?
I give them a rough idea prior to going into those 3 to 4 IPL sessions because I want them to have an idea because it is expensive for patients. I mean, when it comes to not so dry eye that's not ocular rosacea, I mean, sometimes we're only doing those once a year. When it comes to ocular rosacea, I really tell patients we need to be doing this at least twice a year because you're a more severe case. What we're doing is really targeting those blood vessels. This is the best treatment option for you. Everything else that we're doing is treating downstream. This is the only upstream option we have. So I'm oftentimes telling ocular rosacea patients we're going to need to be doing this every 3 to 6 months, kind of in that time span.
Hmm. Wow, this was a great, we should have had slides and we could have recorded it as a lecture. This was really good. This was a lot of fun. I love hearing your perspective. I think any of these sort of conversations are good for those of us who are even in dry eye to hear other people and how they're doing it, and also to affirm that we're doing it the right way, or at least the same way as somebody else, and hearing about the recent research. So super, super great information. Thank you for sharing.
Of course, I'm glad to
Yeah.
be here.
Yeah, we'll have to do it again. I know that ocular pain is another one that you experience a lot in your practice. So maybe we'll have to bring you back and do another conversation around that if you'd be up for it.
Yes, and there are
Yeah.
actually a lot of tie-ins between
Oh,
neuropathic pain and rosacea too.
yeah,
So they both
absolutely.
can affect the nervous system.
Yeah. Yeah. Well, very cool. Well, again, thank you, Dr. Abbott, for being on the podcast. And thank you for listening to this episode of the Optometric Insights Show. Make sure to like and subscribe. You do me a favor, send this episode to somebody else, possibly somebody who's in the dry eye space, and share what Dr. Abbott has been discussing with us today. Thanks, everybody. Have a great day. Here's the tough truth. For every 1 hour we spend with patients, we're stuck doing 2 hours of administrative work, charting, prior authorizations, inbox messaging. And it's not just us. Up to 70% of our team's time is spent on non-clinical work. This isn't why we got into healthcare, and patients feel it too. Many say that they no longer feel truly connected to their providers and the healthcare practices. I've been working with virtual partners for over 10 years, and I can tell you not all virtual staffing companies are created equal. When we found Team, we realized how much better this process could be. Now, we've been working with Team for the last 2 years, and they didn't just find us a name on a resume. They helped us choose the right person, trained them, gave us onboarding system, management tools, and support us to make our virtual team feel like they're really part of our office. Now, our virtual team handles documentation, prior authorizations, billing, patient phone calls, other patient communications, you name it. Our in-office team has more energy. Our patients get more face-to-face time with both my office team as well as me as a provider, and I get to be the kind of doctor that I wanted to be in the first place. If you're ready for a virtual revolution in your office that actually works, and you're looking for a partner that helps you do it right, visit hireteam.com. That's hire, HIRETEEM.com. Big thanks to Team for supporting this podcast. Visit hireteam.com. That's hire, HIRETEEM.com. And thank you to Team for supporting this podcast.